It's my great pleasure to welcome everyone to the second in the series of presentations on legal issues arising from the coronavirus. I'm delighted that George Horvath has agreed to do this talk on technical and legal barriers to widespread testing in the early coronavirus pandemic in the United States. George earned an MD from Temple University, and he practiced cardiology and cardiac electrophysiology before going to law school. He then came to Berkeley Law and graduated from here in 2014. He then clerked for Judge John Noonan on the United States Court of Appeals for the Ninth Circuit, and he is now a fellow in public law at Berkeley Law, and he focuses especially on federal and state regulatory agencies, statutory common law, constitutional law, and particularly federalism. And so with this, I'll turn it over to George. My great thanks to you for doing this presentation for us today.
Well, thank you for having me. So this is going to be a little bit of an unusual talk for a law school because part of it's going to be very technical and sciencey. But I think in terms of understanding the topic, that's going to be important. There's been a lot of media coverage about testing for coronavirus infection in the United States. And that media coverage typically starts off with something like what went wrong. But even the expert commentary makes it pretty clear that there have been problems with getting testing ramped up to where we need it. I'm just thinking of Dr. Anthony Fauci's comment at the press conference a few weeks ago that testing availability in the United States was a failing. And so just at the outset to give a brief abbreviated timeline for this pandemic, right? The earliest reported case was in China in mid-November, although it's pretty clear that there were some known infections probably back into October. China first reported this disease to the World Health Organization on December 31st, 2019. 12 days later, Chinese scientists announced that they had not only identified the causative virus, but had sequenced its entire genome, which was a major step forward and is vital in terms of getting testing out. We had our first reported case in the United States on January 21st, and the first test for the coronavirus was approved by the FDA under a process that we'll talk about on February 4th. And then that test turned out to be quite problematic. And although it was working well for the CDC, it was not working well at other labs. And so we didn't have a lot of testing done using the CDC test until some revised instructions and approvals were put out on March 15th. And beginning on March 12th, the FDA started granting emergency approval for commercial tests. What we have now is, I think, something on the order of 80 to 85 commercial enterprises that are making these tests and distributing them. But I put up some comparison numbers with South Korea simply to show that the rate at which the United States has ramped up has been extremely slow. And so I want to look at a number of issues related to testing in the United States. I want to look first at the rationales and goals of testing. And I want to look at the techniques and particularly the barriers, the technical barriers that have impeded our ability to get a rapid response. A lot of testing going. Then I'll focus on the statutory and regulatory frameworks, which in some cases have impeded our ability to get testing up and running, and in some cases have facilitated that. And then at the end, I briefly want to touch on some policy decisions that have led to the dearth of testing in the United States. And so I put up these two quotes. One is Vice President Pence, who was quoted in the Washington Post last week saying, in essence, that if you're not sick, you don't need a coronavirus test. And I wanted to contrast that to what a standard virology textbook says, which basically says that if we're going to look at things like how is an epidemic going to progress, what's its economic impact going to be, what's its impact on the overall workforce and economy going to be, we need data. We need tons of testing data. And it's easy to criticize politicians and others who say things like what the vice president said, But I think these two quotes get to an important underlying issue, which is that there are different reasons for testing. Pence is focusing on individuals. The Fenner and White textbook is focusing on sort of broad policy level approaches. And so what I would suggest is that if you really want to understand what's going on and you really want to design a system for the next virus, you really need to look at testing on at least 3 different levels. The first is that there are going to be millions of people who are at risk. Providers need to know who to treat, who to isolate, who to follow closely, who to hospitalize. And so here we need an individual level testing program. And here Pence's quote might be quite reasonable, that for an individual, if they're not symptomatic, there may be not a strong rationale to test them. But at the next level up, at a public health level or a containment level, this is based on the epidemiologist's understanding that epidemics are the result of small local outbreaks within a subpopulation. And then that's where most transmission occurs. If you think about the original outbreak in the nursing home in Seattle, or the outbreak in certain communities in New Rochelle, New York, all right? These are small local outbreaks that sort of devastate that subpopulation. And then they're spread further and wider by a small number of individuals. And so at this level, you want testing to interrupt the spread. You want to be able to identify individuals who have the disease, to isolate them to prevent the spread. You want to be able to trace their contacts, and you want to be able to isolate their contacts. If there are treatments available, treat the contacts, but at least prevent them from spreading the disease. And then at the policy level, to make decisions like, do we close borders? Do we close schools and businesses? Do we issue stay-at-home orders? We really need population level data. We need to collect and test samples from vast numbers of people, symptomatic as well as asymptomatic people, so that we can understand how the virus is going to spread, how extensive it's already spread, when is it going to be safe to reopen the economy. And each of these sort of levels of testing might support different kinds of tests. All right, the sensitivity of the test you want, the specificity, the rapidity that you get results back, whether or not it can be performed at a point of service like your primary doctor's office. The importance of each of those takes on a different valence depending on whether you're talking about individual, public health, or policy level testing. And I would say that, one, none of the discussion that I've read or heard so far has adequately approached this on a granular enough level. And two, when we really sit down to create a program for approaching the next pandemic, because one is going to come, we need to take these different levels into consideration. Now, having said that, for the time being, all of the testing that has been done for the coronavirus has been done using one particular modality, and that's by detecting the genetic material of the causative virus from the upper airways in people who are suspected sufferers, and that's using a technique we'll look at called polymerase chain reaction testing. And the low rate of PCR, polymerase chain reaction testing in the United States, really has a number of determinants that are sort of having some complex interactions with one another. So first of all, this is a very complex testing technique. I want to walk through that briefly. There are at least 2 partially overlapping and sometimes conflicting statutory and regulatory frameworks that govern testing. And then third, something that I'll touch on a little bit at the end, are a number of policy and implementation choices that have been made both before the pandemic and in the early phases. And so in order to understand the technical barriers, which I think account for a lot of the slow ramp up in testing here, I do need to go through a bit of the science and technology involved. And so this slide is designed just to show the testing cascade, what has to happen in order to figure out if someone has COVID-19, the disease caused by the SARS-CoV-2 virus. And so the first thing that has to happen is you have to get a specimen. You have to collect tissue from the place where the virus lives, which early on in infection is in the upper airways, basically the very, very back of the nasal passages. All right, and so to do that, we've all seen the photos of the drive-through testing facilities with drivers sitting there in their car with a very long swab being inserted back into their nose. You have to do this right. You have to get the sample from the right location way in the back of the airway, or else you're not going to pick up the virus. It has to be collected on the right kind of swab. It turns out that some swabs, depending on what they're made of, kill the virus, and you can't detect it. Some of the medium that the virus is stored in kills the virus or doesn't support the virus. And then these specimens have to be shipped frozen in the right condition, right? Once they're received by the lab, because this is a virus that's made of RNA, if you remember high school biology, right, there's DNA and there's RNA, these viruses are made of RNA, you have to extract the RNA from the sample, and that's gonna involve some very technologically advanced reagents, equipment, and techniques, the kind of things that aren't gonna happen in your primary doctor's office. These are gonna be done by labs capable of conducting the most complex level of testing. Once you've extracted the RNA, turns out you've extracted the RNA from everything. The host, that means the person's cells, any other bacteria or viruses, as well as the SARS-CoV-2 virus if the person is infected. And so now you have to detect it, and that's where PCR testing comes in. This is really probably the most complex laboratory test that's done on a regular basis anywhere in the world. What this involves is taking a tiny amount of genetic material and amplifying it, multiplying it over and over to the point where we can actually detect its presence. And the problem is that you have to amplify only the genetic material that you're looking for. All right, and so there are real difficulties in making sure that this technique can find the virus if it's there, but not get false positives, not say that the virus is there when it's not. So a number of problems exist. First, any sort of upstream error can invalidate the results. If you don't obtain the specimen correctly, store it or ship it correctly, if you don't extract the RNA correctly, you may have an invalid result. And even if you obtain the specimen on a different kind of swab or extract the RNA using a different kit than what the test you're using has been validated for, you may not have valid results. All right? And so then once you get results, you have to determine whether those results are valid and whether disease is present. And so I want to just point out some of the reasons why testing has been slow to ramp up in the United States at each step of the way. And so first of all, these swabs, which seem like the simplest thing, they look like an overgrown Q-tip, but they're actually much more complicated, are only made by a small number of manufacturers. And we've had worldwide shortages beginning fairly early on in mid-March. Part of that is that at baseline in non-pandemic times, there's a shortage of these swabs. This isn't something that a lot of manufacturers have really jumped into making. We now have skyrocketing demand, and one of the major suppliers is based in northern Italy. And so when northern Italy went into lockdown in early March, that supply dried up. Additionally, these are an FDA-regulated product, and so it makes it difficult for new manufacturers to jump in and fill the void. The tools and machinery needed to isolate the RNA, again, as I said, is very, very specialized. We've had reagent shortages reported in early March, so this was one of the earliest shortages. As demand skyrocketed, the manufacturers that are making these have not been able to keep up with the demand. Fortunately, there are more manufacturers of these reagents, and because of the position of this test in the testing chain, it doesn't contact human beings and it doesn't deliver a diagnosis. These are not FDA regulated, and so it's going to be easier for other manufacturers to step in and fill the void. However, if you start to substitute, if your lab test has been validated, if your PCR test is validated on, let's say, the QIAGEN RNA extraction, which is what the CDC test was validated on, and you're going to substitute another manufacturer's RNA extraction kit, you're going to have to go through a very lengthy process of validating your test results. All right. And then there's the test itself, the PCR test. All right, and so here again, you need equipment that is very large and complex. These aren't going to be available at most points of services like provider's office. As each test has been developed, so what happens is that people who develop a test, beginning with the Centers for Disease Control, they have to develop a probe, a little stretch of DNA that is identical to the virus DNA and specific for the virus DNA. All right, and once they do that and they create the right set of reagents, they can run the real-time polymerase chain reaction test. That test has been validated typically on one machine. So when the CDC released its initial test, it said, this has been validated on one manufacturer's RNA extraction kit and one manufacturer's PCR machine, which limits other labs to either using just that equipment or going through a very lengthy validation process. All right. Other reasons, technical reasons that the ramp up was slow, the machine that the CDC validated on is capable of running 96 different samples at once, right? One full testing cycle takes about 4 hours, but a lot of those 96 samples are controls. And the way the CDC set up its instructions, testing labs were only able to use about half of the samples. So at most, you could run about 50 samples at once. So in a day, any lab might be able to run just a few hundred samples. And then it turned out that the CDC's original test was returning a high rate of inconclusive results. And so when that test was the only available test that had been developed, it wasn't being used in labs outside of the CDC to any large number. And so there have been a number of technical issues related, one, to the complexity of the testing, two, to shortages in some very basic supplies as worldwide demand has skyrocketed. And then three, in the sort of interoperability problems that using different manufacturers' products at different steps of the way has created. And so that's the sort of scientific and technical basis. Now, I want to turn to the statutory and regulatory barriers that have been issues. And I really want to focus on three general statutory provisions. The first is the Food, Drug, and Cosmetics Act, and in particular, the Medical Device Amendments, which provide the FDA with authority over medical devices, including, as we'll see, all of the materials used in this testing. Second are what's called CLIA, the Clinical Laboratory Improvement Amendments, which gives CMS, the Centers for Medicare and Medicaid Services, authority to regulate laboratories where this testing is done. And we'll see that there's an odd and sometimes conflicting overlap between the FDA and CMS regulation. And then third, I want to look at the Project BioShield Act, which includes the emergency use authorization provisions, which has provided the route to the market or the route to testing that we've been using. And so when you're looking at FDA regulation, the first important question is, how is the product that we're looking at defined? Because the definition of a product is going to determine which set of authorities the FDA can bring to bear. And so Section 321 of the Food, Drug, and Cosmetic Act, as it's codified, provides a very broad definition of drugs. There are multiple prongs to this definition, but the relevant one are articles that are intended for the diagnosis of disease in man. And along with the other provisions in 321G, this creates a diagnosis of drug that's so broad that the FDA says that conceptually all the products we regulate meet the definition of drugs. The next provision, subsection H, then carves out a section of drugs, a group of drugs that are also devices. All right, and so these would include instruments, apparatus, implements, basically mechanical devices. But notice as you go on, this also includes in vitro reagents. All right, so that's going to mean all of the PCR testing reagents that are intended for diagnosis, all right, in man, and which don't act in or within or on top of the body, are going to be defined as devices. And so what that means is that the nasopharyngeal swabs are devices, the PCR machine are devices, but so are the PCR reagents. And so the various testing kits that have been created, beginning with the CDC, are regulated as medical devices. So how does the FDA regulate medical devices? Well, under the medical device amendments, it's a risk-based regulatory scheme. So low-risk devices, devices that can have their safety and effectiveness assured just by following the same old general requirements that everything has to follow. Registering your manufacturing facility, following certain good manufacturing policies. Those are low-risk class 1 devices. The highest risk devices, the kind of devices that if they malfunction, present a threat to life or permanent health, or class 3 devices. The intermediate risk devices are devices that have a level of risk somewhere in between. These are devices where if you follow certain special requirements, performance standards and reporting obligations and so on, you can have a reasonable assurance of safety and effectiveness. So the MDA then, based on the risk categorization, creates a number of routes that a manufacturer can take to bring its product to market. And relevant here is the route that's taken for the intermediate class 2 risk devices, because that's where all of the relevant technology that we're talking about for COVID-19 testing falls. Basically is the pre-market notification or 510K pathway. And this was designed in part to provide a more rapid, simple way to get products to the market than the very extensive testing protocols that are required for high-risk devices. The manufacturer has to show that its product is substantially equivalent to a product already on the market. It's either got the same technology or it's got somewhat different technology, but we can show that it's safe and effective, as safe and effective as something already on the market. And so that is the pathway through which all of the products that we're talking about, nasopharyngeal swabs, PCR machines, and the various specific testing kits, the materials that are needed to run the virus test, have been approved. And so I did a little research, and I've done research on FDA approval in the past. I looked at 510K clearances and how long does it take the FDA to approve a product through 510K? Because if you're a manufacturer and you want to bring a new test onto the market, you're going to have to bring it through the 510K process. In fact, every year there are a new set of tests for the plain old seasonal influenza, right? This year's seasonal flu is a different set of viruses than last year's. So how do manufacturers bring those tests onto the market? It's through the 510K pathway. And so how long does it take the FDA to clear a new product? In 2019, there were, I think, 2,332 new clearances issued through this pathway. It took a mean of 119 days. The median was 96 days. Even for microbiology panel approved products, so the relevant panel that would approve the kind of technology we're talking about, it was 88 days. And so what that means is that if we were going to rely on this approval pathway to get testing ability out into widespread use, if a manufacturer had submitted its application on January 12th, the day that China published the sequence, the first day it would have been possible to create a test, that approval would have come through sometime about now. So obviously that's been an impediment to getting testing out in widespread use. And so the workaround has been an act called the Project BioShield Act, which was passed in 2004. And this was largely designed to provide a rapid way to get out into use so-called countermeasures, treatments against the kind of chemical, radiological, or nuclear weapons that might be used in a terror attack. And so what the relevant provisions of this act do is it permits the Secretary of the Department of Health and Human Services to bypass the FDA's pre-market requirements. So the FDA doesn't have to go through the 510K process to approve a product. In this case, the testing kits for the coronavirus disease. And so it provides a more rapid way to get testing out. And so how does this actually work? Well, the first thing that has to happen is that the Secretary of HHS has to find that emergency situation exists. And once that finding is made, the Secretary can then, on a case-by-case basis, issue an emergency use authorization, allowing a non-approved product to be used in clinical practice. And so there are a number of ways that the Secretary of HHS can determine that an emergency situation exists. Two of them rely on other departments, right? So the Secretary of Homeland Security or the Secretary of Defense might find that there's a military emergency, or the Secretary of HHS can find there's a public health emergency, or one of the secretaries can identify a material threat that's caused by something like an infectious agent. Now, the typical authority, and the one that's been used here, falls under subsection C, where the Secretary of Health and Human Services determines there's a public health emergency, right, that affects national security, and that involves a chemical, biological, radiological, or nuclear agent. All right, and so that language sounds very similar to the language used in the two preceding sections and might seem to indicate that this would only be valid for sort of the weapons of war, terror attacks or biological attacks. But this has been interpreted much more broadly. And so a number of emergency use authorizations have been issued in the past 15 years under this pathway. And so I just sort of presented on this slide a number of situations where emergency use authorizations have been granted, going back to treatment for possible anthrax attacks in 2004, which was made by a determination by the Secretary of the Department of Homeland Security, but others for testing involving the MERS epidemic in 2015, the Ebola outbreak in 2014, and the Zika virus epidemic in 2016 have also been done under this emergency use authorization provision. And that's what happened in this situation involving the COVID virus. On February 4th, HHS Secretary Alex Azar determined that there was a public health emergency with significant potential to affect national security. And so finding that there is a public health emergency in existence, HHS is now able to invoke its emergency use authorization powers. Now, what has to happen in order to to grant an emergency use authorization? Well, the criteria are different than what's required for approval under the 510K pre-market pathway. Remember, under the 510K pathway, manufacturers do have to submit some data, and importantly, they have to provide enough data that there's a reasonable assurance of safety and effectiveness, that the Secretary can find that there's a reasonable assurance of safety and effectiveness. For an emergency use authorization, the requirements are different. So first of all, the standards are lower. The finding can be based on the totality of the evidence that exists at the time. So if there are clinical trials that are available, they have to be considered. But if not, the Secretary can make an emergency use authorization based on whatever data is available. The language is different, right? The Secretary has to find it reasonable to believe, right? Doesn't have to have a reasonable assurance, just reasonable to believe that the product may be effective, all right? And that the known and potential benefits outweigh, but it's just a matter of belief. It's a lesser standard here. And then they have to find that there are no other alternatives or that there are shortages that prevent create this emergency. And so this is the authority that the FDA has been invoking. This is the authority under which the FDA approved the CDC's original test on February 4th, beginning on the 12th of March, has been approving tests manufactured by other entities. And then following under its, or applying its statutory authorities, HHS has also further lowered some of the standards. And so in terms of the kind of evidence that supports safety and effectiveness, these emergency use authorizations are letting companies making these testing kits to use computer modeling to show that, yes, it can detect the virus with adequate sensitivity and specificity. It's not requiring them to do as extensive a set of tests as they otherwise would have had to do. The FDA has been waiving the requirements with good manufacturing protocols. One of the problems is that as a company is trying to create a test for the coronavirus, they may not be able to create all of the reagents that they need. They may have to buy them. And the good manufacturing process requirements would somewhat impede that ability. So by waiving them, it's making it easier for manufacturers to create these tests. And then, as we'll talk about in a little while, the FDA has also made it easier for labs to create their own tests and use them. But so what this has done is it has permitted entities like the CDC, large companies, academic labs, to develop tests and to distribute them within the United States. And so as of Friday, 28 different tests have been approved. And so now the makers of these tests can sell and ship these tests to labs all around the country. And if the labs have the technology and are capable of doing this, they can start to run these tests. But there are a huge number of clinical labs in the United States that can do testing on their own. They can develop their own tests and run their own tests. And so what about them? And that's where the statute called CLIA, the Clinical Laboratory Improvement Amendments, come in. And this was a statute that was designed to expand the regulation of clinical labs. So it turns out that hospitals, freestanding testing centers, other places are quite capable of creating their own lab tests. Some of those are quite simple, but some of them are complex to the point of the PCR testing that we're talking about. And so what CLIA does is it divides labs into different categories. It sets out the requirements that labs in each category of complexity have to adhere to in order to be certified. All right, and so in order for a lab to do testing, it has to be certified. But if a lab is already tested for high complexity testing, like PCR testing, and it develops a PCR test for the coronavirus, under CLIA, that lab can start to run tests on its own. It has to validate the test before it does so. But CMS, which implements the CLIA regulations, won't look at the validation for some time. And it may not be until the every 2-year renewal of the certificate comes up. And so this would, if CLIA is the only regulator involved in running a lab or regulating a lab, would have allowed sort of thousands and thousands of labs across the country to attempt to develop their own tests. However, the FDA has maintained that it also has oversight authority over all of this complex testing. But the FDA has long said that it exercised its discretion and wasn't going to regulate testing that was developed within a lab and used only within that lab. So a so-called LDT, laboratory developed test. So at the outset of the crisis, if a lab was only regulated by CLIA, it might have been able to develop and use its own tests. But the FDA has taken a harder line and has said that labs need to obtain clearance. And then only on February 19th did the FDA finally say that it was okay. And through a guidance document, the FDA said that labs that are regulated by CLIA can develop their own test, and they don't have to apply for an emergency use authorization. They can go ahead and implement that test. Once they implement the test, they start doing it. Within 15 days, they have to apply for an emergency use authorization. But so what this has done now is to have allowed potentially thousands of private labs in hospitals or freestanding labs in universities to begin developing tests. As of this morning, 81 labs had informed the FDA that they'd validated their own tests and were beginning to offer testing. But again, even this may not be sufficient to ensure a rapid ramp up in these complex testing techniques, given the sort of limitations on supplies and reagents. But at least now we've opened up the ability to have a broader set of entities bring testing online. So one thing that's clear is that there's some confusion about the role of the FDA in regulating these laboratories. It's unclear what the FDA's authorities are, and it's unclear how the FDA intends to act. And I would say that this uncertainty has resulted in something of an obstacle to developing more extensive testing. And so just before I close, I want to talk about a number of what I'm referring to as policy or policy and implementation decisions that have also impacted, largely slowed down the expansion of testing in the United States. And so beginning right with the Centers for Disease Control, when the CDC originally created the test for the coronavirus, it created a test that was much more complicated than anything anyone else was doing. Most other countries had created tests that looked for 1 or 2 stretches of RNA to identify the coronavirus. The CDC was looking for 3 different stretches of RNA. And as I said, one of those 3 stretches created problems in that the test was giving results that appeared to show the presence of the virus when the virus wasn't there. Why the CDC decided to go with a test of such complexity isn't clear. And I haven't been able to find any information about what they were looking at the time. The second was a decision by the CDC early on to establish restrictive testing criteria. The emergency use authorizations that the FDA have granted state that testing can be done only for patients who meet the CDC requirement. And initially, the CDC said that the only people who met testing criteria were people who had traveled to an endemic area or people who had contact with someone who had been infected. And so part of that was probably a resource allocation problem. The CDC realized there were a limited number of tests and it wanted to conserve the tests. But the longer that that restriction stayed in place, the fewer tests that were able to be done. And now that's been loosened up substantially. The third is that initially the CDC has decided to allocate the test kits equally across the states, meaning that if the CDC had created 200 test kits, each state was going to get 4, regardless of whether the population was that of California or Wyoming. All right. The FDA determining the scope of its emergency use authorizations and its sort of regulatory power over CLIA regulated labs has been a policy decision that's been problematic. I think that the sparing use of the Defense Production Act, not ordering manufacturers to produce the testing supplies that are needed, has been an issue. And then finally, going back to decisions that were made even before the crisis began, there is a strategic national stockpile that has things like ventilators, but also might be able to stockpile things like diagnostic testing materials, the swabs that are needed, RNA extraction materials that are needed. Those have been assigned a low priority by the Strategic National Stockpile. And so although there are some stocks available, they're not as robust as we would like. And then finally, underlying this all, I think is a decision or an ongoing series of decisions that has basically said that for our laboratory testing, we're going to rely on a highly decentralized system of testing that involves the CDC, but also involves hospital labs, freestanding labs, commercial labs, in a multipolar regulatory system involving the FDA and CMS, often in conflicting ways, and hoping that that system can adequately respond to a rapidly changing emergency. And so, unfortunately, there's no one cause, no one easily correctable cause that explains why the United States has lagged behind so many countries in getting testing up and running. But I think that that's as clear or at least as thorough an explanation as I can give at this point. And so I'm happy to go into any of this in more detail, and I'm eager to hear other comments and thoughts.
And I think
Okay. Okay, so if you have a question, you can send it to me in the chat, or you can raise your hand and I'm happy to call on you. I've got a couple already. So can you please explain more the Korean contrast? Stockpiling, regulatory structure, centralization, better political leaders? These are all questions.
And those are all possibilities. There's a lot that I don't know about why South Korea was able to ramp up so quickly, but a couple of things. First, they were an early mover. And so I think they ramped up their testing really before the worldwide demand had outstripped a lot of supply. And so, a lot of the shortages that we started to encounter were coming up in early to mid-March. All right, but Korea, as I showed, had already crossed that 10,000 tests a day threshold well before. And so I think that, just moving early sort of obviated a number of problems. I don't know yet the sort of regulatory structures within Korea. I do know that there were very early meetings between the Korean CDC officials and major manufacturers who produced testing kits in Korea. I think there were 4 manufacturers. And so they may have had a more centralized way of bringing these products online. I don't know that. And so that sort of comparative analysis, I think, is going to be very helpful as we look ahead at how to deal with the next pandemic that's going to come up.
Why don't they require tests to be validated with more than one manufacturer's equipment?
So this, there's a little more complexity to it. So first of all, I think that in order to get a, to achieve a reasonable, a belief that a test is safe and effective, showing that it works with one manufacturer's technology is adequate to do that. Now in practice, what happens is that they'll grant, the FDA will grant an emergency use authorization. It will initially specify the manufacturers whose RNA extraction kits work, whose nasopharyngeal swabs, whose PCR reagents may work. As more and more labs do these tests, once they validate that test on a different, let's say a different RNA extraction kit, they'll report that to the FDA. And then the FDA can report out that, okay, we've had validation from other labs that say that this other manufacturer's RNA extraction kit also returns valid results with this specific test kit. And so I think that they're trying to balance the sort of delay that would happen by requiring a manufacturer to validate on multiple platforms and yet still provide that information where it's useful.
Was there a reason that the CDC chose not to use the tests from the World Health Organization?
That's a great question, and I do not know what information the CDC was looking at. When they're designing the test, they're trying to do a couple of things. So they basically have to create so-called primers, little stretches of DNA that are going to bind to the virus, right? The virus genome, the virus genetic material. That's what sets off the amplification process in the PCR testing chain. They need to pick sequences that are specific to the coronavirus. They don't want other viruses to get amplified and return a positive signal when, maybe it's just a coronavirus that causes the common cold. So they want to be very, very specific in the sequences they choose. But also, we already know that there are a number of different strains, slight genetic variants in the coronavirus that are circulating throughout the world. And so if you're too specific, you may miss certain strains if they start to circulate within the United States. And so I don't know which of those, but I think one of those probably explains why the CDC created such a complex test. Either they were looking for more specificity, or they were trying to sweep in a broader range of the COVID-19 causing viruses. But that information I don't think has been made public at this point.
Could you please explain again the impact CLIA had on the restriction of testing for COVID-19?
So I think that the way I would look at the CLIA amendments right now are largely that had they been the sole regulating framework, it would have been, the ramp up for testing would have been much quicker. Again, because under CLIA, if your lab is already certified to do high complexity testing, your lab can develop its own in-house test, all right? Your lab can take that sequence that was published by China on January 12th, create its own set of primers or order its own set of primers, create its own set of reagents, validate that test on its own machinery, and then run that test only in-house, only in that lab. And so it might have been possible for labs to really ramp up quite quickly. Now, the one impediment CLIA places is that if you're a lab that's capable of doing high complexity testing, but you don't already have a CLIA certificate, you have to apply for one. And originally, this was a fairly slow process involving a lot of written exchanges, actually written in hard copy exchanges. CMS has moved to try to speed and expedite the granting of high complexity laboratory testing certificates. That's a way that CLIA might have slowed the expansion of testing, but by allowing, or presumptively allowing the creation of these so-called homebrewed or laboratory developed tests, CLIA, as I said, would have sped the development of testing. It's where the FDA stepped in and exercised what it sees as its authority to also regulate lab testing that I think has created some of the bottleneck.
Was the South Korean testing for less RNA stretches? And should the USA move towards a test that doesn't require 3 stretches?
Yes and yes. I believe that the South Korea test looked at 2 stretches, and the way it was set up was it looked at 1 stretch of DNA. If that gave a hit, suggested that the virus was there, they then would analyze for the 2nd stretch to confirm. The CDC originally was having the test look at 3 distinct stretches of genetic material. The most recent guidance out from CMS and the FDA have said that it's permissible to look even for a single highly specific stretch of DNA. So we've definitely been moving away from that high complexity to a more simplified testing scheme.
Can you talk more about the EUA? Is it a blanket authorization to loosen up the criteria for all COVID diagnostics, or is it granted for each individual product?
Right. So the way this works is that there is a general declaration that an emergency condition exists. And so that would be if the Secretary of Homeland Security or Defense declares that there's a military emergency, or that the Secretary of HHS finds that there's a public health emergency. That's a blanket declaration. That now invokes the FDA's authority to issue emergency use authorizations. But then each specific test kit or each specific product needs its own emergency use authorization. All right, so the declaration of an emergency just triggers the authority. That authority is applied on a product by product basis.
Can states authorize their own testing without the FDA?
So there are provisions of CLIA that permit the states to take over the certification process. That's not an area that I know a lot about, but there are at least 5 states that have notified the CMS and the FDA that they are going to take care of certifying individual labs who want to develop and use their own in-house testing.
Antibody testing seems like it will be increasingly valuable. Which of these will apply to such testing?
I'm sorry, Whitney, the last sentence of that question broke up on my...
Sorry about that. My internet's being a little dicey. Antibody testing seems like it will be increasingly valuable. Which of these will apply to such testing?
Right. So good question. So the situation is, I think that we may have at least one antibody test that's now been approved. So antibody tests are attractive for a number of reasons. These can be much simpler tests. In fact, some of the tests that you're familiar with, like the monospot or the rapid strep tests, where you go into your doctor's office and they do a throat swab and, you know, swab it, and within, you know, a short period of minutes, they come back with the answer. Those are very simple tests. And so those, depending on how they develop, may actually be available on a point of service basis. And the way CLIA works is that these kind of tests that pretty much any of us could actually do in our own home. It would be like doing a home pregnancy test or some other, you know, an insult, you know, a blood sugar test. Labs that want to do those tests can get a waiver under CLIA. Those are called waived testing facilities. And so that you can do that, your provider's office, you know, a lot of providers' offices have a CLIA waiver so they can do a monospot test or a rapid strep test. And so it may be quite feasible as these antibody tests come online that point of service testing becomes a reality. Now, one of the problems is that the sensitivity and specificity of these tests is unclear right now. There are some early reports that at least some of the developed tests are giving incorrect results in 1/3 to 2/3 of cases. And so I think that we're going to need to see more extensive validation before we really want to rely on them. But again, depending on what you're using them for, right, that may be, you know, if they've got, you know, if they're right 2/3 or 3/4 of the time, and all it's going to do is guide you in terms of telling that individual whether they should isolate themselves at home, that might be acceptable. And so I think we're just going to have to see how this plays out. It's just too early right now to know. There's another kind of antibody test where they actually draw blood and they look for the presence of antibodies. That's more the gold standard of exposure and potentially of immunity. And so those kind of tests might become important as we look at questions like, is it safe to reopen the economy, right? Who's safe to go back out in public? Well, if I know that I've got a huge antibody titer because I've had COVID-19 and I'm now immune, then let me out in public, right? And those would be the people who might go out first. I don't know of any serologic tests based on blood that are approved right now. I think those are going to start coming online very soon.
How do you think the COVID-19 pandemic will affect U.S. regulation of local testing in the future?
You know, that's a good question. It's very unclear for a number of reasons. First, because the FDA's position on this is unclear. As I mentioned, historically, the FDA had said it was taking a hands-off approach. It had authority to regulate local labs, but it wasn't. And then in 2014, the FDA said, no, we are going to actively regulate certainly high complexity labs. They got a ton of pushback from the laboratory industry. ultimately backed off on that, never promulgated a final regulation, created a working group. And so where the FDA comes down is unclear. It's not clear how this is going to impact the FDA. There's also some legislation that's been introduced into Congress. There's something called the VALID Act, and I don't remember what the acronym stands for, but basically would represent a transfer of authority, as I understand the act, from CMS to the FDA. The FDA would actually have a broader regulatory role over clinical laboratories. I think it's too early to know right now how this is going to impact the relative responsibility of the FDA and CMS.
I am actually going to call on someone to ask a question. Nick, go ahead.
Hi, how are you doing, Professor Horvath?
Good, nice to see you.
Nice to see you too. Long time no see.
Yeah.
Generally, my question really is, how does CLIA determine what is a complex test? And I ask this because I kind of want to push back on the narrative that it's a complex test.
Mm-hmm.
I have a number of reasons why I wrote this down in the chat, but generally speaking, qPCR is one of the most common techniques in all biology labs. There's qPCR machines in every single academic lab you can think of, in every single medical school or research facility. And there's hundreds of thousands of Americans who would be qualified to run these tests. And there's a couple other reasons too, and that's in the chat. But generally speaking, I'd like to have an idea of why CLIA counts these as complex tests.
Right. So CLIA actually has a sort of a complex scoring system that looks at a number of factors, assigns each factor a score on, I think it's 0 to 3, I might be wrong, and then adds it up and you get a score that says how complex the lab is. Part of it is how complex the equipment is, how much training is necessary, how much human interpretation is necessary. Nick, I think part of the problem is that you're looking at this at a very sort of with very high expectations. I mean, CLIA realizes regulating everything from a university academic research lab down to a primary care doc's office with very limited capacity and really very limited expertise, and even maybe steps below that for some other locations. And so I think what you're considering to be high complexity is sort of up here compared to the way the CLIA regulations craft them. The other thing I would say, though, is to push back a little bit on your pushback. The PCR technology, yes, it's widespread, but again, the risk of amplification resulting in false positives is definitely there. Again, the fact that using a different nasopharyngeal swab might ultimately affect sort of the threshold level that you pick to call positive versus negative outcome in your PCR, I think hints at how complex all of this really is. And so, yes, I agree that this is in widespread use, and these machines, I mean, once you set them up, they run and they run on their own, and they're very, they're very good at what they do. But there are, relative within, within the complexity structure here, these do, I think, justifiably fall at the more complex end of things. We might have to agree to disagree on that, but.
Yeah, we'll have to disagree.
All right. Can you discuss the policy and public health issues around what information should be given to the public on test results? 2 specific things. 1, apparently U.S. jurisdictions have been less specific about where clusters of infections are located than in South Korea, for example. And 2, the U.S. has also declined to give statistics broken down by various demographic characteristics, such as income, race, etc. Would such information be helpful?
Well, I think that, I think that there is a good argument to be made that the more information that's made public, the better. I think that, some of the concerns that have motivated these limits, the decision not to disclose information about frequency based on race or national origin, I think comes from concerns about truly negative consequences on people. I mean, people from China, Chinese Americans have been encountering, incidents, based on the origin, this virus starting in Wuhan, China. And so I think there's been some concern about sort of exposing groups to, adverse incidents or bad incidents based on that. I know that some county health officials have pushed back on releasing more detailed location data based on HIPAA requirements. I don't quite understand why the federal privacy rule would prevent, let's say, Santa Clara County from talking about how many cases there are in each of the cities in Santa Clara County, but that's been the rationale that their public health authority has given for not disclosing that information. I think that I don't have a lot more that I can say about the concerns at this point, or how I think this ought to play out, other than personally, I like to see more information. I think it helps to formulate responses. I'm going to leave it at that.
Can you say anything about the technical / bureaucratic / legal challenges for doing the ideal kind of population sampling epidemiologists need for modeling?
So I think that that's going to be an important step moving forward, is to figure out how to actually do this. And I think that there are a number of ways that you can imagine that sort of testing coming about. And so what we're talking about here, I think what we're talking about here is the issue that I described as sort of policy level testing. You want sort of, massive testing on people, whether or not they're symptomatic, basically population sampling. And so how can you do that? One way might be just to double down on this sort of decentralized polycentric system that we have, to try to remove as many barriers, get the FDA to stand down, let CLIA regulated labs create their in-house tests, make some more robust attempts at stockpiling the swabs, the reagents that we would need, try to facilitate the development of tests early on, and just try to push testing out through the existing mechanisms. A second might be to rely on some sort of civilian military synergy, because many of these same concerns about testing and treatment and biological agents are things that the military is deeply concerned about. The original law that created the emergency use authorizations was purely aimed at protecting military forces. And I think that there are some sort of expertise on both sides that might be synergistic. And then a third idea might just be to create some kind of a monitoring program or a sentinel program. I don't know, maybe have, hundreds of thousands of people with swabs in their home, and on instruction, they do a swab, and there's a system set up, and FedEx delivers them all to the CDC, and the CDC has a robust set of testing abilities, and it runs tests when need be. But I think that we're going to need to really sit down and think through a more organized pandemic response. I think that there are advantages to having this sort of decentralized polycentric regulation system that we have. It creates flexibility. Maybe the next pandemic isn't going to rely on PCR testing for its testing modality. But it does seem like we're going to need something a little more centralized to get population level testing. And what we've seen really since the turn of the century, right, with the pandemics and epidemics and threats that we've had SARS, MERS, we've had the avian flu, we've had Zika, we've had Ebola. I mean, that's at least 5 major biological threats in less than a 20-year period. We pretty clearly need a more robust and hardened response in place.
Okay, and I think this will probably be the last question for the day, since we are almost out of time. How do you see all of this playing out in terms of making a vaccine available and also a reliable test that someone has had the virus and can return to the workforce?
So I think that vaccine development is going to face a somewhat different but not completely distinct set of regulatory issues. There, I think that unlike testing, there's going to be probably a higher, a greater need to ensure safety and effectiveness. It's one thing if your test, misfires and gives a false positive or a false negative, but the vaccine, we're talking about vaccinating a huge percent of the population. And so, some of the waivers that I talked about, waiving the good manufacturing practices, that's not going to be as acceptable for vaccine development. Allowing computer modeling to determine whether or not a test should come online, that's not going to work for vaccine. We're going to have actual clinical data. And so I think that there's just a completely different valence there that, it's going to follow a somewhat different trajectory. In terms of the serologic testing and the return, I just don't know enough about where that stands in development right now to comment on sort of how that's likely to play out through the regulatory process.
I hope that everyone will join me in thanking George for his wonderful, informative presentation. We would give you resounding applause now if only we were in the room with you.
Right.
But I know that it took a huge amount of time to prepare that. And just on behalf of everyone, I want to express our gratitude for you putting together this presentation and delivering it us this afternoon. And hopefully you can see on the screen, many people are sending thank you messages right now.
Thank you. Thanks.
Thank you. And thanks also to everybody for joining in. And we'll continue these every Monday and hope you'll continue to be part of them. Thanks, everyone. Have a great Monday.